Hi, everyone. Welcome to the HealthFirst Infection Prevention and Control podcast. We're excited to be talking about a very timely topic today, testing on COVID-19, which tests and why. A lot of tests out there. We're going to be going through some key areas in this podcast, the two diagnostic tests, so some of the test accuracy and pitfalls, and then also we'll conclude with COVID-19 precautions. So we'll be guided by our two leading experts from their respective fields, both in the medical and dental fields, Dr. Scott Cohen and Dr. Fiona Collins. So without further ado, I'll pass over the mic to Dr. Scott Cohen.
Thank you, Grace. So we're going to talk tonight briefly about testing and a couple of things we really wanted to help frame tonight, and that is, what are the different types of tests out there, and also, what's their usefulness? Because, in general, I think people feel like if a test is positive, it means the patient has disease, and if the test is negative, it means the patient definitely does not have disease. And I think, especially when Fiona starts talking more about testing accuracy or sensitivity, specificity, we'll see that it's not 100%. And just because a test is negative does not mean the patient does not have disease. And just because it's positive doesn't mean they do. So we're going to start out talking about the diagnostic tests specifically. And we'll make a differentiation here between diagnostic tests and others. The diagnostic test we're talking about is to diagnose disease, versus like the antibody tests, which are to diagnose disease in the past. So the two broad types of diagnostic tests we have, and realize there's probably going to be hundreds of different brands out there, but the two broad types we're going to talk about tonight are antigen testing, and then we're going to talk about PCR testing. And I think everyone's probably heard these, but may not 100% be aware of what the utility is, or more importantly, where some of these tests are not helpful and could be potentially misleading. And I think Grace and I will be or Fiona and I will be getting into that a little bit later. So antigen testing is very simply, and the best example I can give is strep tests or even pregnancy tests. Strep tests, when you put fluid containing like saliva or other bodily fluid onto a card, there's a series of chemical reactions that test to see if a specific antigen is there, usually a protein. And that really just determines, is the antigen there? Is a piece of what you're looking for there? If it's there, the test considers itself positive. If it's not there, the test considers itself negative. There's upsides and downsides to that. The upsides are, of course, if the antigen is there and you actually have disease, it's great. Sometimes though, I'm a family doc and I treat strep. The antigen can stay in someone's throat for strep disease for weeks. So I could test them 3 weeks after they were positive and treated, and they could still be positive. So there's upsides and downsides. The same is true for COVID. It works very similarly, just different antigens, different proteins that we're testing for. So PCR testing is very different. PCR testing uses a piece of DNA, RNA, and the system actually finds it, amplifies it, and measures it to determine positivity. There's two potential positives for that. One is it can actually determine usually much lower levels of a virus in someone's secretions than if you're using antigen testing. The other positive about it is it's a bit more specific, meaning you have to have what you're looking for on the PCR, which is DNA, RNA, in order for it to be positive. And what happens is typically with these PCR tests, the test actually amplifies what's in the sample such that you can actually read it. And I think, going into our next section here, Fiona is going to talk about how does this affect accuracy and, what are the pitfalls in terms of sensitivity and specificity. So I'll turn it over to you, Fiona.
Thanks, Scott. So as we look at sensitivity and specificity, obviously what we're looking for is a high level of sensitivity and a high level of specificity. That means in the case of sensitivity, you're getting very few, if any, false negatives. In the case of specificity, you're getting very few, if any, false positives. So really, as a generalization, you may be asking yourself, or have to ask yourself, which is worse? So let's diverge for a little moment and look at the case of a cancer patient. You could have somebody who has a very slowly progressing cancer, and let's add on that they're pretty old, just to make it even better. Or you could have a cancer that's very aggressive in a young patient. So what's going to be worse there? Well, a false positive may cause you to have a biopsy that you didn't need, which is obviously not a good thing. But if you're looking at the older person with a slowly progressing cancer, a false negative in that situation isn't going to be as detrimental as a false negative in an older patient with a slow-moving cancer. Basically, something else may well catch the older person before it ever becomes a problem. Whereas the younger person with an aggressive one, you obviously want it, if it's there, you want to know so that you can treat it as quickly as possible with a better chance of less severe morbidity and avoiding mortality or death. Now let's look at COVID-19, which is worse there. Well, if you have a false positive and it's COVID-19, really, if you think about it, the worst that can happen is you end up in isolation. You have a repeat test and you find out, actually, you didn't have it after all. Not pleasant, but it's only isolation. If, on the other hand, you have a false negative, you think you don't have it, you may meet people unless there are really strict regulations in place in your location at that time. And so you're basically spreading it, thinking you do not have COVID-19. That's obviously a much more severe problem. So if you had to, hopefully you have high sensitivity and specificity, but with respect to COVID-19, a lower specificity isn't as bad as a lower sensitivity. So I would rather have a false positive than false negative, basically. Yeah. When we start to look at that in the context of the testing that Scott's been describing, the molecular PCR testing has very high sensitivity, typically very high specificity as well. As we start to look at the point of care ones, the antigen tests, those generally have high specificity. So that would mean a low level of false positives, but they can have false negatives that could be up to 15 to 20%, depending on the test that's being used. So that's one of the things to look for if you're considering using a point of care antigen test, is don't just take for granted that they're saying it's high accuracy. You really want to know about the specificity and sensitivity to make sense of which one's going to be the most useful in your given situation.
Yeah, that's great. Fiona, how about maybe we go through a few scenarios and we can talk through, what would be the most appropriate test, when it would be used, and, how you can interpret the results. Like, for example, I'm the medical director of a fire department. I recently had some firefighters who were exposed to someone incidentally inside the building, ostensibly was well, turned out was not. What do you think about post-exposure testing? What tests would you think we should consider doing, if any, and when?
If it were me and I suspected that a patient were positive or was showing symptoms, I would choose to do a PCR test. It's got a higher sensitivity and specificity. I'll get a more reliable result. It does take some time in comparison to many of the antigen tests. But my sense of it would be ask the patient to quarantine themselves, isolate themselves, and wait. Now it's typically 2 to 3 days. Initially, it was about a week, and there was a backlog. So sit out those 2 to 3 days and get an accurate result.
Mm-hmm. Okay. I think, and when we think about, so a patient who's well and was exposed to someone who ostensibly had COVID, I usually would recommend the PCR test, but I would tell them typically, because they were just exposed to someone yesterday, say, for example, I would recommend they don't be tested for several days. Generally, day 5 is probably the most useful. And I would recommend at that point, on day 5, they get tested by PCR testing because of its sensitivity at lower levels of presentation of the virus. And I think that's been borne out lately. But the other option, and this is one reason I wanted to bring this up here, the other option is just to not test people at all. If they were exposed, just to quarantine, for the now 10 days that the CDC is recommending, and just move on, because we can't test everyone exposed, especially with the number of positives that we have. But I guess then moving on, one of my interests is mass screening. So my daughter's in college. What are your thoughts on that in terms of which test and why?
I think the general recommendation is if you're doing mass screenings, if you're screening on a regular basis, you could do the antigen test and repeat it over time, repeat it several times, and use it as really more of a monitoring system than anything else. Now, if you're testing the sewers, the wastewater in the sewers, that's a different matter. Since your daughter's at college, maybe you would like to address that one.
Sure. In my mind, mass screening is best done by the cheapest and fastest method out there. And that, in my mind, is antigen testing. And also, the fastest method in 15 to 20 minutes done in a CLIA waived way, meaning you don't need lab techs to do it. Matter of fact, we just found out that there's a home version of, one of the tests that's coming out over the next couple of days. But that is the antigen testing. It's very cheap. It's incredibly quick. It's easy technically, so it's a CLIA waived test. It has, as Fiona said, it's high specificity. Yes, it's low sensitivity, meaning it does have a high false negative rate up to 15, even 20%. But the reality is, in big populations like college students, they do it on a weekly or biweekly basis. So you're, in some sense, overcoming some of that low sensitivity by just repeatedly doing it. And the goal is to just pick up as many people as possible who are positive, but not necessarily everyone. It's mass screening, so you can't have the perfect test, but it's a good test for that. So I think the last one, you hinted on it already, Fiona, and that is if you have someone who's clearly symptomatic, or they're undergoing some sort of procedure that will require significant aerosolization, like, say, for example, they're undergoing a bronchoscopy or something like that, and you are doing pre-procedural testing, I think we both agree that would most likely be a PCR test, right? Yeah,
where possible, that I would agree with that. The other interesting thing is you were talking about people that may be too soon. They may show up negative and then show up positive later. And then you mentioned the home test, and the one that just came out, as we just discovered, is supervised, and it's a nasal swab. Now, I'm glad to hear it was a nasal swab and not a nasopharyngeal, because I can't imagine how anybody other than an expert could do that properly. And of course, improperly taking sample is another reason for negative tests. So it is supervised, which is good news. The other thing they're looking at, of course, is salivary testing, which removes anything particularly skillful at all. All you need to be able to do is spit into the tube. So that would be a good idea.
Absolutely. And as you mentioned, the effluent testing, which is kind of a neat way of doing testing, where there are some organizations that are testing wastewater effluent from dormitory style housing. And if it's negative, you can safely assume that almost everyone is negative in there. If it's positive, that's when you test everybody in that building to figure out who's contributing to the positive. Neat way of doing it, similar to batch testing that we see in some areas of medicine as well that we've been looking at. But yeah, that's kind of neat. So I guess, Fiona, you wanted to talk about now, how do we actually prevent some cases? So I'll turn it to you for that.
Right. So obviously, in the general public scenario, if you are suspected or have been diagnosed with COVID-19, then you're obviously going to be hopefully self-isolating, but certainly quarantining within your household. So that takes care of that. Obviously, the clinical situation is very different. So what do you do there? Well, obviously, there's triaging, there's screening, and all of the other good stuff that is now part of COVID-19 guidance. I think going back to the testing, one of the interesting things is if you do a PCR test, it's going to take 2 to 3 days to get the result. Mm-hmm. So in a dental setting where it could be part of a treatment plan, you could do a PCR test, you get the result 2 to 3 days later, and the patient's been exposed now. And at that point, the patient may have acquired SARS-CoV-2 and COVID-19. They're probably asymptomatic still. It's unlikely they've got any symptoms. So what do? Do you do a point of care test? So I think in some settings, there is some value to doing a point of care test, provided you're aware that it could be a false negative, and you are screening, you are testing, but you cannot guarantee that that person does not have COVID-19. So you should still be taking precautions. Obviously, if it comes back positive, that's a different situation. And unless it's an emergency situation, you are going to not treat them that day.
Absolutely.
I wondered if, from your perspective and in your setting, if there's anything you would like to add to that that would be perhaps a different consideration.
No, I think, we use in the medical setting, we use really the same practical precautions. We use a universal precautions, both for, prevention of Hep B, HIV, and other diseases, universal COVID precautions to turn any exposure into a low risk exposure. That means goggles and masks. And then any known COVID positive patient clearly should be, full level 4, such that, you are, protecting yourself as well as possible. I think people are doing that for the most part. I've been quite encouraged by that. And I'm glad that if you look at the literature on medical folks, that our conversion rates are lower than the general population in general, which I think is kind of neat, and a call to really thank our coworkers for doing a great job.
Yeah, and I believe that applies to both medicine and dentistry. There's surveys that have been done and studies in dentistry now, and they're also showing that people have adhered to it, and they do have low rates. It's not higher. So it's really, really good news that everyone is following the extra precautions with COVID-19 guidance. I think the other interesting thing is, and we'll be talking about vaccination in another podcast, but I think the other thing is it's unclear at the moment whether a vaccinated person can transmit the virus and spread disease, even although they are highly unlikely to acquire the disease themselves. So that's another reason not to sit in our laurels, if you like, and still to take all of the precautions as well until there's herd immunity, wearing a mask in public. So.
Absolutely. All right. Well, that was excellent discussion. I hope we gave you all some, practical, useful information on some of the positives, no pun intended, and pitfalls of some of the tests that are out there. Clearly, there'll be more to come, and realize, as this was recorded, in mid-December, the likelihood of change over the next even day or two is high. So, please look for our vaccine podcast, which is coming up very shortly, actually, likely will be out at the same time as this one. And we really thank you for joining us tonight.
Thank you.